Hello everyone, my name is Dr. Colette Smart and welcome to my lecture today. I'm a registered psychologist and an associate professor of psychology here at the University of Victoria. And as of January 2024, I am also the research scholar in residence for mental health and substance use at Island Health. And I would like to begin my talk by offering acknowledgement and respect of the Lekwungen peoples on whose traditional territory the University of Victoria stands, and the Songhees, Esquimalt and Wasanic peoples whose historical relationships with the land continue to this day. So I have 3 learning objectives for our time together in this talk. And we're going to talk about what is complex trauma. How is it similar and also different from what we usually think of as PTSD? How the symptoms of complex trauma may masquerade as other types of problems. And also some therapeutic approaches and how to support loved ones, people in your life you know who may be suffering from complex trauma. I do want to preface by saying that no overtly traumatic material will be discussed in this talk. And also, even though I am a registered psychologist, this talk is provided for informational purposes only and does not constitute psychological or medical advice. But having said that, I do want to walk the talk in this presentation and use a trauma-informed approach to sharing the material with you today. I work with many Indigenous people, and they often like to speak about starting and ending in a good way. And so we're going to use that approach in this talk. So the first principle I want to share that we use in trauma-informed practice is the idea of containment. And you can think about this literally like a container, but in a mental health context, the containment refers to the skills and strategies we use to hold difficult emotions and then to put them away when we need to move on to other activities. And we can think of a container as a physical space, like you might think of your home as a container, an interpersonal space, so a loving relationship, or an internal psychological space where we can put those difficult thoughts and feelings to the side until we need to come back to them. So I would invite you, if you would like, for a moment, you could even pause this recording and create a container in your mind. When I do this with clients, I have them visualize. It might be a box. Many clients that like to use a cedar box. Could be another type of container, and just anything that's on your mind right now that isn't necessary to attend to, you can just allow it to go into your container and then close up the lid and then put it away, and it will be waiting for you when this presentation is over. Another approach that we use in trauma-informed practice is grounding. And so when we are dealing with a difficult traumatic experience, it often takes us out of the present moment to another place and time. And so one of the ways that we get back to a sense of safety is by grounding into the present moment. And a very effective way to do that is using our 5 senses, as well as some gentle movement. And it can bring us out of a difficult emotional experience back into the here and now in a gentle and calming way. And so some examples of that is you could just feel your feet on the floor right now. Can you feel your feet? Can you feel your feet inside your socks or your shoes? Maybe applying some gentle pressure to your hands. Some people like to suck on an ice cube, or there might be a specific scent like a citrus or a lavender, or maybe even the sound of a bell. Something just to engage your 5 senses. And so you could think about, is there anything that you want to use as a grounding object or movement today? And you may wish to have this with you for the rest of the talk, particularly if you are someone watching this talk who has been affected by trauma. Before getting into the material of this talk, I want to share briefly about how I came to be practicing and now researching in this area. So as a scientist practitioner, that means I am someone where my clinical experiences influence my research and teaching, and also my research and teaching influences the clinical work that I do. And in 2017, I decided to start a private practice outside of UVic that would help enhance my teaching and supervision of graduate students in our clinical psychology program. And as a neuropsychologist, I work with adults with various types of acquired brain injury, older adults with cognitive issues, and also people with chronic medical conditions such as cancer and chronic pain. And I started to observe that the usual evidence-based treatments I was accustomed to were not working. I was seeing people showing trauma responses, but not meeting the typical presentation of PTSD or post-traumatic stress disorder that I was more familiar with. And these clients often had various other diagnoses, such as major depression, generalized anxiety, and other diagnoses. And so it led me to go into a journey of discovery about what it was I was seeing and how could I better support my clients. And it has led me on this pathway to learning much more and becoming passionate about complex trauma and being able to educate clients, healthcare providers, and the public on this really important but often hidden topic. And our research lab has begun studying different facets of trauma over the last several years. And because of this work and my interest, as of January 2024, I'm now the research scholar in residence at Mental Health and Substance Use and Island Health to explore this topic more. So what I'm going to share with you today is initially from the clinical experiences I had, but also the state of the research evidence, and also what we have heard from survivors. So I want to begin by making sure we're on the same page about some important terminology. So trauma is a word that is being used very commonly in our current conversation, and sometimes there's confusion about what that actually means. So experiencing stress is just a normal part of life. We all experience different types of stressors, like losing a job, or maybe a separation or divorce, or even the death of a loved one. But these are often different from what we consider traumatic events. Traditionally, we have thought of traumatic events as big events that are life-threatening and overwhelm our ability to cope and manage in the aftermath. So one example might be natural disasters like an earthquake or a hurricane that displaces many people from their homes. Another one is car accidents. That was many of the clients that I initially saw in my practice were people who'd been motor vehicle accidents. Assault is another common type of traumatic event. And then people serving in the military or even first responders such as police and firefighters. Now, what's interesting to know is that some estimates indicate that as many as 76% of people will have been exposed to a traumatic event by adulthood. So that's a huge swath of the population, a clear majority of the population. But not everyone develops traumatic stress. Most people show resilience, and so I think that is encouraging and important to know that even if you yourself have been exposed to a traumatic event, it doesn't mean that you are traumatized. A much smaller amount of people develop traumatic stress disorders, of which PTSD that we're going to talk about is one such disorder. Recent research indicates that in Canada, the prevalence of PTSD is about 9.2%. And it's also interesting to note that Canada, for some reason, seems to have a higher rate of PTSD than many other countries. And there's some debate about why that might be. It's important to separate exposure to a traumatic event from traumatic stress or a traumatic stress response. And I really like this quote by Dr. Gabor Mate, who is a physician that's based in Vancouver and has written many books about trauma and mental health. And he says, trauma is not what happens to you. Trauma is what happens inside of you as a result of what has happened to you. So in that quote, he is separating exposure to the event from the aftermath of the event. And it's the aftermath that's the traumatic stress that we're going to talk about. So as I mentioned, the diagnosis that probably most people are familiar with is PTSD. And the DSM-5 is the book that we use in mental health and psychiatry to make clinical diagnoses. And so according to the DSM-5, which is the most recent version of the DSM, a person has to be exposed to what they refer to as a criterion A event, which is one of these big traumatic stressors. And then they have to show certain responses to that traumatic event. So one of them is intrusions. So when you hear people talk about having flashbacks, where they feel like they're literally reliving the event over and over again. Nightmares is another example of intrusions, and people with PTSD tend to have really poor sleep for that reason. Avoidance is another symptom. So images, thoughts might come into a person's mind and they do everything possible to avoid those thoughts. They might try and avoid certain feelings. They might avoid external reminders. So, for example, it's not uncommon if someone has been in a car accident, they might avoid being a passenger or even a driver in a car while they're still dealing with PTSD. Negative alterations in mood and cognition. So this is where we see people can develop a very low kind of depressive mood, where they lose a sense of joy or meaning or purpose. They might really blame themselves or blame someone else for what happened. They might tend to isolate and withdraw from other people and show a decreased capacity to be engaged with life. And the fourth cluster of symptoms are alterations in arousal and reactivity. So if you've heard the term hypervigilance, so being on high alert all the time and always waiting for the next big bad thing to happen. Also having an exaggerated startle response. So somebody might be very jumpy when they hear certain unexpected noises. And generally, to meet the criteria, the symptoms have to have lasted for more than a month and also impair a person's daily function. So it might make it difficult to work or engage in relationships. And another interesting point is many times it happens immediately after the event, but for a certain amount of people, it can actually be a delayed onset. So, for example, I did a little bit of work with some local police several years ago, and I sometimes heard stories about there would be an accumulation of events, and it wouldn't be till years later where something else happened and then the trauma came forward. So we've talked about PTSD, and now I want to segue into talking about the main focus of this talk, which is complex trauma. Dr. Judith Herman is a very, very well-known and well-respected trauma clinician. And in her book in 1992, she first is credited with using the term complex PTSD. So we can see here that there are three of these same core symptoms: a sense of threat, a sense of avoidance, and also re-experiencing. So that's the nightmares and the flashbacks and feeling like the trauma is happening again in real time. But there's also these three unique components of complex trauma. And the first one is interpersonal disturbances, so sustained and ongoing problems in relationships with other people. Negative self-concept is the next one. So that's having a really distorted and negative view of yourself, or being very unclear about your identity. And then the third one is affect dysregulation. So affect is another way of talking about our emotions moment to moment. So having very abrupt and very noticeable changes in how we feel from moment to moment. And these seem to be more specific to complex trauma than PTSD. This is what we call single incident PTSD. So it's one major event. Sometimes people refer to it as a shock trauma, like car accident, assault. It's a single event, and then someone has changes in their experience after that. Complex trauma is different because it's more likely to occur in situations that are prolonged, repetitive, and inescapable, and also very much in a relationship context. So some examples of traumatizing interpersonal situation would be child abuse and neglect. That's probably the most well-known one. Also intimate partner violence. Even though much of the PTSD literature came out of study of the military, now we're actually understanding that many military and first responders may be better understood in terms of having complex trauma. Refugees or concentration camp survivors, survivors of cults or high demand groups, and other conditions of systemic oppression or even intergenerational trauma. And another thing to note is with complex trauma, looking at any one single moment of a person's experience might not seem to meet the threshold of a trauma, but it is this context of being prolonged, repetitive, and inescapable, and often in a key relationship with someone that should be usually trustworthy. So adverse childhood experiences, which pertains to child abuse, neglect, and other types of maltreatment. This is probably our best known cause of complex trauma. And so Vincent Felitti and other colleagues in 1998 conducted what has now become the landmark ACEs, or Adverse Childhood Experiences study. And they assessed 17,000 patients' self-reports of 10 key childhood adverse events that were broadly classified as maltreatment, so abuse and neglect, and also household dysfunction. So that would include things like my parent or caregiver was struggling with a mental illness. I had a parent or caregiver or someone in the home who used substances or was involved in the criminal justice system. And they found that there was a clear association between these adverse childhood experiences and the kind of physical health and chronic disease, as well as mental health outcomes that people had in adulthood. And they also found what is referred to as a dose-response relationship. So the more ACEs you're exposed to, the higher your risk for adverse outcomes. And particularly people who had 4 or more ACEs seem to be at the highest risk. Now, parallel to what I mentioned before about PTSD, many people are actually exposed to ACEs more than you might think. So about 60% of the population, and this seems to be the case for many Western nations, seem to have been exposed to at least one ACE. But that doesn't mean everybody has adverse outcomes in adulthood. So it's considered a risk, but it's not deterministic. People can have resilience, and this is a good thing to know. However, a dose-response relationship of many ACEs, or sometimes what's referred to as toxic stress, does have an adverse effect on the brain. So it affects cognitive development, so things like our ability to pay attention, our memory, our executive function, so our higher order cognitive functions such as problem solving. And this seems to be through the mechanism of our HPA axis becomes dysregulated, and it's really thinking about the brain as just bathed in cortisol, which is our stress hormone. And that leads to emotional and behavioral dysregulation. So dysregulation means not being able to manage ourselves internally in a way that meets our environment or helps us meet our goals. And so this dysregulation seems to underlie many of the mental health and substance use challenges that people who've been exposed to ACEs deal with in adulthood. We also see that people are more susceptible to chronic disease, accidents, and injury. So for example, in the types of clients that I work with, we know that exposure to ACEs, for example, women who are exposed to child sexual abuse are at higher risk for stroke and cardiovascular disease. And finally, ACEs impact our ability to form or maintain relationships. And unfortunately, this can carry into adulthood that might make people more susceptible to further abusive relationships in adulthood. So Christine Courtois and Julian Ford are 2 of the very well-known, well-respected researchers in the area of complex trauma. And I think this quote from them is really helpful. And they say, adverse interpersonal childhood traumas lead to breakdowns in the psychobiology of the child, which leads to a lack of integrity in the body-mind relationship, interference in the formation of a coherent identity, and disruptions in attachment, impairing the development of healthy and reciprocal relationships. And so, again, to make this point, what makes complex trauma unique from single incident PTSD is really that broken relationships are at the heart of complex trauma. And relationships, particularly for children, set up the building blocks for our psyche and also how we move through the world. And when those are disrupted, it turns our whole world upside down. We also know that one of the biggest predictors of resistance to or recovery from PTSD is social support. So it's a cruel irony that in the case of complex trauma, people themselves are the source of the traumatic stress, which is really captured by the statement, the one who is supposed to love me is the one who is also hurting me. So attachment refers to our ability to bond and connect with other people. And D.W. Winnicott was a psychiatrist who worked with children who really was one of the pioneers in the study of attachment. And so if we think about complex PTSD negatively affects our relationships, really at the heart of that is our capacity for secure attachment. And we know, for example, in terms of parenting or caregiving children, you don't have to be perfect, you just have to be good enough to have a secure attachment. But in the case of complex trauma, what we more often see are insecure attachment styles, and these can look slightly different depending on the person. So it might be what we call anxious or ambivalent, so someone who's always concerned that the person might leave or abandon them. Conversely, somebody might have a more dismissive or avoidant attachment style where they feel like it's safer to not attach to people and people are not necessary in their lives. And then the most impaired attachment style is what we call disorganized. So you can think about this as having the gas and the brakes on at the same time. So there's a desperate need to connect, but also a desperate fear that that will lead to becoming hurt. As I mentioned, there's a lot of literature on adverse childhood experiences, but it's also interesting to think about disruptions in attachment amongst adults who are in relationship. And one example of this is people who are in cults or totalitarian organizations or systems. And this is a really great book by Alexandra Stein, who's a social psychologist who herself was in a political cult. And she came out of that and recovered and then started to study this from an academic perspective. And she talks about the mechanism of disorganized attachment is what maintains a cult or a totalitarian system. And she talks about particularly being in relationship to the leader who often has some form of narcissistic personality or maybe even antisocial personality. So she uses the term charismatic authoritarianism. Daniel Shaw is another researcher in this area. He is a psychodynamic therapist based in New York who was himself a cult survivor. And he refers to traumatizing narcissism. And it's sometimes been said that intimate partner violence is like a cult of two. So what happens to someone when they find themselves in the context of a prolonged, inescapable, broken relationship? Well, it seems to affect what's been referred to as our window of tolerance. And this is a term that's often credited to Dr. Dan Siegel, who's a child psychiatrist who also focuses on the use of mindfulness. And you can think about our window of tolerance as our baseline capacity to deal with life stress. And so sometimes this is talked about in terms of our parasympathetic nervous system, or what's called the rest and digest system. So when we're in our window of tolerance, stressful things may be happening, but we feel resilient, we feel confident, we can manage those stressors. And when the immediate stressor's over, we can relax and preserve our resources. However, if you've been exposed to trauma and dealing with traumatic stress, it seems to really narrow our window of tolerance, and it doesn't take much stress to pull us out of the window. And this can lead us to either or both of the following responses. Hyperarousal. So you've probably heard the terms fight or flight. There's also a freeze response, and that's this idea of having the gas and the brakes on that I spoke about earlier. And here you really see an activation of the sympathetic nervous system, so our energy and our arousal goes way up, hence hyperarousal. But another type of response is hypoarousal. And so this is sometimes referred to as collapse or submit. And so we feel hopeless, we feel helpless, like there's nothing we can do to change our situation, and we just give up. And that's associated with what's referred to as the dorsal vagal system. And literally the most extreme example of this is under heightened stress, someone can literally pass out and lose consciousness. These are some of the responses we see in complex trauma when someone is exposed to stress. Their window of tolerance is very narrow, and it could be a simple, difficult discussion with a loved one can put someone into a hyperarousal state or a hypoarousal state. And sometimes people gravitate more towards one or the other. Or what I've often seen in people that I have worked with is they'll spend a certain amount of time in hyperarousal, and you can only stay up there for so long, and then they crash into hypoarousal. And what happens when people end up out of their window of tolerance? So they end up experiencing something called an emotional flashback. So earlier I spoke about flashbacks are a common symptom of PTSD. So let's say, for example, you were someone who had been in a car accident. So a typical flashback might be you see yourself back at the moment of impact, or you see yourself back in the driver's seat, or some moment of the traumatic event. And usually there's a clear visual component to it, which gives you a clue that I am flashing back to the traumatic event. Emotional flashbacks, and this is a term that is often credited to Pete Walker, who is a complex trauma therapist and survivor himself. Emotional flashbacks are different from flashbacks in a classical PTSD. And they tend to be triggered by unsafe people, especially, but sometimes unsafe situations, and they bring people out of their window of tolerance. And they may represent symptoms that are actually, you can think about it as emotional regressions to an earlier time, or body memories that are pre-verbal or implicit. So especially for people who've experienced child trauma, they may be emotionally flashing back to something that happened before they could even verbalize or articulate it, so before the age of 3. And the body remembers what has happened. And this is what makes these symptoms really confusing, because there's no clear visual image or no single event that we can tie that experience to. All we know is that we feel really bad, really unsafe with this person in this situation, and it's really hard to get out of it. And over time, these can lead to negative beliefs about ourselves, about other people, and about the world around us. So complex trauma is often hiding in plain sight. It's very insidious, because as I mentioned before, it's not just one easily pinpointable single event, but it's chronic interpersonal adversity that just becomes normalized. Especially if you grew up in a difficult childhood, you probably don't know any different. You might not have any other frame of reference, so you might just think that's how relationships are. As we move into adulthood and then we find ourselves struggling with mental or physical health, these symptoms of complex trauma can masquerade as other disorders. And sometimes this means that we have unsuccessful treatment because there is not an accurate diagnosis of the problem. And I really like this quote. It came from Pete Walker's book, but it's attributed to John Briere, who's a really well-established trauma researcher. He said, if CPTSD, that's complex PTSD, were really given its due, the DSM would shrink to the size of a pamphlet. So I mentioned before, the DSM is our diagnostic manual, which is a very thick book. And so he said, if we really understood things through this complex trauma lens, there would be less need for all these individual discrete diagnoses. Just to kind of illustrate this point, if we think about if we are in our window of tolerance and we're feeling calm and safe and with people that we can trust, this is what activates what's known as our social engagement system. So you can think about this as regulated relatedness. Your nervous system feels regulated, it feels balanced, and that allows us to connect with other people. However, if you find yourself in an emotional flashback, you might end up having one of these other responses. So the fawn response, which is also credited to Pete Walker, you can also think about this as the desire to please and appease. So this is still being related to other people, but it's coming from a place not of authentic connection, but of fear. So trying to figure out, how can I keep you happy so that you don't hurt me? A fight response. So this is when we see somebody has dysregulated anger. So it's anger that might be out of proportion to the situation or is uncontrollable. We might see somebody who's really controlling or micromanaging. And in the most extreme situations, this is somebody who might end up with a diagnosis of either borderline or narcissistic personality disorder. The flight response, this is where you might see somebody who worries a lot, who seems to have a lot of anxiety or obsessive compulsive behaviors, somebody who's a workaholic or engages in what we call process addictions, like doom scrolling on social media. You might also see this as somebody who has a compulsion to rescue or save other people. A freeze response, this is where someone becomes very dissociated, they're kind of checked out from the present moment. But it could also show up in more subtle ways like procrastination or even ADHD-like symptoms. And then at the most extreme end, we see the collapse, submit response. So this is a feeling of inertia. There's no point, feeling apathetic. It might be depression that doesn't ever seem to go away, and a feeling of learned helplessness and hopelessness, and really the sense that you have no agency to make positive change in your life. Some of the terms that I mentioned on the slide here, these are actual diagnoses. And for people who have not experienced complex trauma, these may be people who can get evidence-based care and it works quite well for them. But what's interesting in the complex trauma context is that these symptoms can be very context dependent. So if a person is in a safe place, in a safe situation, they might be free of these problems. But when they get into an unsafe situation, this is where some of the symptoms come up. So this unpredictability is what makes complex trauma difficult to ascertain. And really one of the first things I do with my clients is provide education about these responses as a way to normalize what they're experiencing and what they're feeling. And this is often a huge relief for people to know that they're not crazy, they're not damaged, they're simply doing what they needed to do to survive. That was what helped them survive the difficult situation they were in. And I always love this quote by Viktor Frankl that really captures that. He says, an abnormal reaction to an abnormal situation is normal behavior. And really, in some level, you can think about it as the person's resilience, that they were able to figure out a way to manage in that situation, even if it's not ideal for their current situation. So in terms of treatments, there were some guidelines that came out from the American Psychological Association about best practices for treatment of PTSD. And the two authors on the screen here, Courtois and Brown, interestingly, they were part of developing those guidelines. And after they came out, they led a series of papers that actually critiqued the guidelines pretty heavily. And a lot of the critique was because they did not really address complex trauma. So they felt that much of the research was over-medicalized, it was too focused on symptoms, there was not enough discussion of the importance of relationship or looking at cross-cultural factors, and also where the body comes into it. Because we know that the body holds many of these memories and experiences of complex trauma. So many people like myself who work with clients with complex trauma tend to use what's called this 3-phase model. And so rather than immediately treating the traumatic stress like we might do in PTSD, we want to spend a lot of time in the beginning building a sense of safety and stabilization. Only then, when the client actually feels ready, then they can begin actively processing the trauma. And then phase 3 is, how do you start to move on with life, integrate your experiences, and make sense of what has happened? So in phase 1, grounding that I spoke about at the beginning of this talk is really important, that a person learns how to ground themselves, resource themselves to the present moment, develop self-regulation skills, and also build social support. And one way that clients often do that is with their therapist, if they have a good therapist to work with. And this quote from Alan Shore, who's a trauma therapist, he says, "The therapist acts as an external regulator by attuning to the client's arousal states and modeling self-regulation." So when we're babies, if we have a good parents or caregivers, we learn self-regulation through co-regulation with those caregivers. So If we didn't get that in our relationships before, we can still learn it in a good therapeutic relationship. And I always like this quote by Maya Angelou. I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And that's really the first important step in healing, is finding someone that you can trust, that ideally would include a good therapist. Thinking about the window of tolerance, how we want to expand our window of tolerance, that's where we want to learn to upregulate, downregulate, and also co-regulate. And this is what helps us manage those emotional flashbacks. And we want to practice engaging these states of regulation on purpose. So not just wait for something difficult to happen, but we actually want to take control and practice these skills ourselves. So some of the ways that we can increase our arousal, vigorous exercise is really good. Might be running, biking, anything else that a person likes to do. Listening to high intensity music. And of course, different types of play. So being with other people in a high arousal state that's enjoyable and engaging. To practice down-regulating or decreasing our arousal, that might be where gentle breathing exercises come in, yoga or gentle walking, having warm baths, blankets, and even comfort from a pet. And co-regulate is where we start to bring those tools into relationship with another person. So it might be a therapist, close friends, or other loved ones that we can trust. And a big part of this is being able to listen to our body and tune into our bodily cues, because our bodily cues are gut reactions about who or what is safe, who or what is dangerous. That is something that gets damaged in complex trauma. So part of recovery is learning how to notice and also trust those bodily cues again. And especially to notice when you do feel safe with another person, to really take that in and use that as a North Star for how you want to orient to other people, how you can know if someone is going to be safe for you. Now, many clients choose to only do phase 1, and they might stay there for a long time, and that's good enough for them. But for the certain amount of people who actually want to move into actively processing some of the traumatic events that have happened to them, these are just a few of the evidence-based treatments that we might use at that point. And again, only when the person is ready, because if it's too soon, then it might not be helpful. So there's more cognitive and behavioral oriented treatments like cognitive processing therapy and prolonged exposure. Prolonged exposure works really well when it works, but it also has a high dropout rate because it is very difficult to tolerate, so it may not be for everyone. Eye movement desensitization and reprocessing, this is actually the approach that I use, as well as somatically oriented therapies. So they involve bringing in the physical body. So things like somatic experiencing, sensory motor psychotherapy, or even mindfulness-based approaches. Now, if you're a person who has complex trauma, it's highly likely that you have organized your whole life around coping and surviving with the effects of the trauma. So this is naturally going to affect your relationships, your work, how you live, how you move through the world. So processing that trauma means that there's going to be potentially a big shift in your identity after you've done that work. So healing means constructing a whole new sense of identity, and this can take time, and it can cause a lot of just change and disruption, but the sense is that you're ultimately going in a more healthful direction. So people at this stage are often trying to make meaning and sense from their suffering. Why did this happen? What can I learn from it? Allowing yourself maybe for the first time ever to identify and live your values, finding a sense of joy and hope and giving yourself permission to live your own life, and discovering loving relationships. And I mentioned before that I work with many Indigenous clients, and this is where the idea of Indigenous resurgence or resilience comes in. So helping clients reconnect with their culture, with their language, with their tradition. And this might be true for other clients or people who've been taken out of their culture or their family, reconnecting with their roots that way. Marshall Linehan devised another very effective treatment called dialectical behavior therapy for people with borderline personality disorder. And she wrote her memoir, 2020, 4 years ago now, which is a really, really powerful book. And when I read it, I was never quite sure, did she identify as somebody who had borderline personality or was it complex trauma? Because to me, it sounded very much like complex trauma. But the main message of her book was the idea of building a life worth living. So rather than having a problem that you treat and you move on, it's really this sense of recovery and resilience and really building the life that you want. That's really the goal that many people have at this phase of healing. So you may have watched this talk and there may be some things that have stirred in you. You might resonate with some of the information that I've shared here, and you might be thinking, maybe this is something that I should investigate for myself. Unfortunately, there's a significant amount of mental health providers that don't know about complex trauma or don't know how to recognize it. And so it's important, if you're seeking therapy, to find someone who is actually going to be helpful, because as I have mentioned throughout, relationship is the most important part. So I just offer you some questions that you might bring to a potential therapist to ask them, do you know about the difference between complex trauma and PTSD? Do you have a background in attachment theory? How do you use relationships in your work with clients? What do you understand about how trauma affects the brain and the body? How do you use nervous system regulation in your work? And what kind of skills do you teach clients in terms of trauma recovery? How successful have clients been in your care? I just share some resources here. These are educational resources, and these can be really helpful if you're just starting to explore this topic for yourself. One thing I will definitely say, if you feel that you are a survivor of complex trauma, please pace yourself so that you don't get overwhelmed. And probably the befriending your nervous system is a good place to start from the resources that I've shared here, because it allows you to learn some skills. It's quite gentle. And then the other books give more information on trauma. Out of the Storm is a really helpful website that's run by survivors. There's information on there, and there's also a discussion forum that you can connect with other people. There's lots of information on there about relational trauma. And then the ISTSS is one of the big research organizations. There's researchers, clinicians, and also sometimes people with lived experience who attend their meetings, but they have information for the public that's based on science and clinical practice. Just want to take a moment to thank the members of my research team and also the people who fund our work. Of course, thanks maybe most of all to my clients, because they're the ones that have really brought me to doing this work. And to end in a good way, as my Indigenous clients often say, I just want to share some quotes here. Freedom is what you do with what has been done to you. In the midst of winter, I found there was within me an invincible summer. We're all just walking each other home. Thank you for your time.